Dear audience, dear colleagues, good morning, and thank you very much to let me introduce my PhD thesis about the novel treatment of advanced urothelial cancer. My name is Mohammed Altenni, and I'm working at a Péterfi hospital as a urologist. My vision to serve bladder cancer patients with compassion, professionalism, and integrity. My mission to provide outstanding clinical treatment for a patient with advanced urothelial cancer in a strong academic environment. According to this, I have two specific ongoing goals. The first one is about enfortumab vedotin, which is a new treatment. It is an antibody-drug conjugate, and the second one about the immune checkpoint inhibitors. So let me start with the first project, which is identifying patients who would benefit from enfortumab vedotin in advanced urothelial cancer. A little bit about background. The 5-year survival for urothelial carcinoma is very poor, and unfortunately for metastatic disease, it's around 5%. Advanced urothelial cancer patients are undertreated. Less than 60% receive the first-line therapy, which is chemotherapy, and less than 10% receive third-line therapy. But we are very happy to have a new treatment, is enfortumab vedotin, in as a new third-line therapy, which is approved in 2022 by the EMA, according to the enfortumab vedotin 301 control trials, because of its superiority than chemotherapy in overall survival and objective response rate. The problem or the issue here that randomized control trials have a strict eligibility criteria, and patients in the real world are less selected, and it's still unknown which patient will benefit from this therapy. So our aim to identify which patient with advanced urothelial cancer will benefit from the novel treatment. Our clinical question: how do different clinical parameters impact the outcomes of EV-treated advanced urothelial cancer patients? With the PECO framework, our patients with advanced urothelial cancer treated with enfortumab vedotin, and we use the exposure pair comparator for different patient characteristics and our outcomes, overall survival and radiographic response, with a hypothesis that enfortumab vedotin provides greater benefit to advanced urothelial cancer patients with specific characteristics. According to this, our clinical implication, enfortumab vedotin might be more widely used in advanced urothelial cancer. We conducted a systematic search in a 3 main database using the search key, as you can see below, and we have a number of hits around 1,600. Our key articles, all of them, it's real-world studies with a big sample size and a limitation for this study that's a retrospective design. Our flowchart of selection, we had 1,680 articles, and after duplicate removal, we have 902 articles, and after title and abstract selection, it was 57 articles with a Cohen kappa 0.9. I worked with Judith Varga. So this is my first project progress. We would like to start the full text selection this week. The second topic about the identifying patients who would benefit from immune checkpoint inhibitors in advanced urothelial cancer. The background here that immune checkpoint inhibitors are a novel standard treatment also, but 25% of patients will benefit from this treatment, while 75% will not. For example, here, patients with a high patients with a higher age has a higher objective response rate. So our aim here to identify which clinical parameters are associated with better response to this therapy. Our clinical question: how different clinical parameters impact the outcomes of immune checkpoint inhibitors treated advanced urothelial cancer patient. We use the same PECO framework, and our hypothesis, immune checkpoint inhibitors provide greater benefit to advanced urothelial cancer patients with specific clinical parameters. Our clinical implication to provide clinical guidance in which patient will benefit more from this therapy. Our systematic search is a preliminary search in our 2 main databases, and we have a number of hits around 3,000. Here we have some of key articles. The first 2 articles are a real-world study, and the first one is very important study because it's conducted here in Hungary by Melinda Varadi and Tibor Szarvas in 2023. And the third article is about RCT. To summarize, I have 2 ongoing projects with the same disease and with a different kind of novel treatment. We would like to submit the first one in May and the second one in August. And thank you for your attention, and be brave to stand for what you believe in, even if you stand alone. Thank you very much.
Thank you very much for the presentation. It was very nice to hear and exciting researches. My question is regarding your first study. Do you plan to use any subgroup analysis regarding the best possible groups to treat with this new treatment?
Thank you. Your question, yes. The main of our study is the subgroup analysis.
About regarding from your first topic, enfortumab vedotin is a very promising therapy in advanced urothelial cancer. Is this therapy available in Hungary?
Actually, it's yeah, but we did not start to use it. So I hope in next year we can start it. So it's very new therapy. It's approved in 2023 by the EMA, and it's difficult to start. But I spoke with friends in Center for Oncology, and they said that they will start it. But in my information, there's no patients had this therapy.
My question arises from the last question from Judith Varga. Congratulations to your talk, it was nice.
Thank you.
And so my question is about your opinion. What do you think, how long time needs such a new treatment modality to become the part in an oncological treatment in the everyday practice? And what can help such systematic reviews and analyses to shorten this time period?
Unfortunately, our experience said that in the last 30 years, we have just one kind of treatment, and it was chemotherapy. And from 2017, there is a new kind of therapy, immune checkpoint inhibitors. And as it's very good therapy, and they started very soon. But the problem here, always we are waiting to start this therapy about 2 years from the, in comparison with the USA. So I hope we will start this therapy very quickly, but I really don't have very good information about when we can.
I would have rather methodology-related questions, since I'm a pediatrician, so a little bit outsider. My first question is, since your clinical questions are really similar to each other, you have the same disease, same question framework, maybe the outcomes are also overlapping. So didn't you consider to have one publication and investigating 2 different drugs? Since except for the intervention, basically everything is the same. Yeah,
I spoke with my supervisor, and this kind of study is very important to support a new treatment, and there is a lack of this kind of study. So we think that it's very important to do more and more kind of the study. And as you can see in the second topic, we have already submitted a new same articles by Melinda Varody, and it's still ongoing. So we need more and more from these studies.
All right. And my other question, you want to investigate the clinical patient characteristics of features. And of course, if you want to conduct a meta-analysis, you need to rely on the available literature, and you need articles which report these data and results based on these clinical features that you listed, age, sex, etc., metastasis maybe. So based on your search so far and the preliminary search, of course, which characteristic will you be able to make this subgroup analysis?
Yeah, for this first, thank you very, very much for your question. For the first topic, we have different clinical pathological or patient characteristic. It's a liver metastasis and a tumor location, and the age subgroup, and also different type for prior therapy. And for the second topic, we have subgroups like smokers and non-smokers, and also the tumor location and age and maybe Belmont risk factors.
Okay, and one last question. How will you handle the fact if, for example, one patient is affected by several risk factors? So you cannot really, separately analyze them. Because someone is also a smoker and also, for example, let's say, I don't know, old. I mean, it can be a risk factor.
Yeah, it's a different question. As I search in the previous articles, there is different kind of subgroups, and they didn't mention that kind of connection between patients, so smokers.
Yeah, probably it's going to be a limitation for your study, because
yes,
usually
course,
that's a fact if someone, investigating quite common risk factors, because it might happen that these risk factors can overlap in different groups.
Yeah.